We are on week 9. This is now 3 more weeks and we're going to be done. This week, we are going to go over musculoskeletal, neuromuscular, chapters 48 and 49. You'll see some interesting concepts for this area. You only have a discussion question this week. Now, be aware, I'm going to be slow on grading the discussion questions because of the amount of projects that I want to get back to you so that you have a chance to get your best grades. So if you're seeing discussion questions not done right away, that's the reason why, okay? And then you have the pediatric dosage calc, which is from your Calculate with Confidence book. And it's just a refresher. Some of the areas, like you don't know what they are. If you want to check your answers, you all know your answers are in the book. So you can check everything. And I know that. And if you don't, now you do. So you can go back and check it. And it is on, your book list. As I said, those pediatric assessments, those are the pediatric assessment project is the one that was due on Sunday. Some of you haven't turned it in. I understand. Remember, you have till next Sunday. Now, you will not get a chance to get a second chance. Everybody else who got it in on time, if you see less than 100, go and look at it. What am I telling you that you should correct? If you're okay with a 90, so am I. If you're okay with an 80, so am I. But if you prefer up more, a bigger grade for your subjective grades, go ahead and turn it in. Just let me know that you've done it. Now, I've scored some of you, and some of you I haven't. I've been trying to, as I get them, as quick as I can. But, I'm one person trying to do them and doing the best job, giving you that information about what I see, what can you do better. And again, and this is preparing you as you go forward into your career. Like me, who didn't know I needed an office in my computer. I still laugh about that. So let's go ahead. Exam 3. We're doing reviews this week. Mine's tomorrow at 2 o'clock. Of course, it will be posted. Also, try to listen to somebody else's. I always say, even though there's a monotony and a monotone in the voice, Professor Morris goes over everything. I mean, it's a little slower paced, but she really gives a good review. I'm a little more upbeat, a little bit quicker, but again, try to get someone else. Professor Chase Pace Chismar teaches just like me, so you might like her voice. Professor Arstenstall's a little bit more long-winded, and then Professor Luminoso, she's in the middle of all of us. So you've got a bunch of professors who give some good reviews. So mine, of course, and do one more, whichever one you want. Now, your exam is next Wednesday. If anybody wants to meet me, it's going to have to be either Monday, Tuesday, because I want you to look at my review first. I want you to study my review first. Come to me for a review, and I'm going to ask you some questions on concepts and try to guide you into what you need to know and how to understand it. Okay? I can help. Especially don't be borderline. I don't want you going in the HESI worried. Now you're worried about the HESI. HESI, I've got a HESI Q&A review. I'm going to do that on next Saturday at 2 o'clock. I do that on the Saturday before HESI week every single quarter. I go over every concept you might see on the exam, and I try to explain it in a way that you're not memorizing. You're understanding what I'm saying. Because as you go to capstone, memorization is not going to pass you. You have to know, understand anemia and red blood cells and what happens and what does the body do and why. How do you fix it? And then, did it work? And if you can do that to every question, you're going to do great with capstone. And coming to that review, I start doing that with you. So you've had the whole pediatric course. You've done your study and you've had your exams. I'm giving you that HESI review. Most students who come to it, study it, and the study guide do extremely well. The mean average HESI score for me is greater than 900. So anybody who needs at 78 and are, oh, but I've not really done well on HESIs, you can with me if you do what I tell you to do. Go to the HESI Q&A. You can start listening to it after exam 3, and we can get you fine-tuned. And I've seen students with 78, 79 GPAs get 99.99 on a HESI, okay? Because they came to me several times, and it was after exam 2, before exam 3. So exam 3, I got with them, did their HESIs with them, reviews with them, and it was 2 of them. And they both, one was 99.40 something, and the other one was 99.99. Again, it got them thinking, okay? So let's go ahead. Let's start. Again, anybody who wants to get with me, send me a message. You can text me, email me, or send a message in Canvas. So let's start with musculoskeletal or articular dysfunction, something to do with bones or joints, right? These pictures tell you the stories of musculoskeletal, broken bones, legs, crutches, and then all that neurovascular things you have to worry about in CAS care. And that top right one is a Pavlik harness, and that's for developmental hip dysplasia. They're born with it. Their hip socket is not in, the femur head is not in the socket. It's here somewhere. So that's what we can help fix it. If that doesn't work, the bottom right one, that cast, a spica cast, we use those for those children to try to get those hip back into joint also. And then the bottom left one is a Buck's traction. You might have seen it in med surge in when you have an elderly patient with a fractured hip to try to keep it pulled until they get to surgery because of pain. Well, in pediatrics, we don't really get fractured hips. Those are the older people, right? With mineral demineralization and calcium, all that stuff. But in children, it's usually a fractured femur. And we pull the leg to pull the femur apart and get the edges approximated because this little break, when it's completely broke, there's little spikes and little sharp edges that hit muscles and nerves, and then the muscles try to pull it. I mean, think about your quadriplex. Are strong, big muscles. They're pulling that bone in and creating a lot of pain. So that Buck's traction pulls it. And that's to get them with a little bout of pain and getting them ready to go to the OR, in a day or two, whatever the doctor wants. Now, children can be immobilized, many different reasons. Congenital, degenerative, osteogenesis imperfecta, which is brittle bone. We're going to that one. What about infections, injuries, crush injuries, anything? And then any child that has a prolonged immobilization, and it could be due to many things. It could be Guillain-Barré, and we're going to go into that later on today, where they are bed rest. And what do we do that therapies to prevent complications of prolonged immobilization? We see things like that decreased muscle strength, that foot drop, right? We see bones not getting nutrition the way they should because immobilized patients usually say they're so sick they probably are intubated or have a tracheostomy. What about that cardiovascular system? Heart and lungs. We're worried about blood clots. We're worried about fluid pooling, edema, all of those things. So these are things as a nurse that we need to think about preventing complications. Now, complications physically, we know, but what about those mental ones, those psychosocial things? Can you imagine a child prolonged hospitalization aware that they have been separated from family, friends, school, and everyone? And it could be 3, 6, 9 months. I've seen children in hospitals that long, just like adults can be, depending on what happened to them. Can you imagine the feelings that they feel all alone? They feel helpless. Sometimes these children become aggressive and they become angry, and it's not because they're upset with you, it's the situation. And nurses can make this immobilization, this separation, we can make it a lot less painful. mean, I would many times take my computer into their room, sit with them, and talk with them, was doing my chart, not showing them, of course, the charts, but just being with them. And sometimes it's all they want. Or I used to always make bows and ribbons and stuff, head bands for some of the younger kids. And we would do them together or color, play cards. I've even played video games. And, just a couple minutes. That's all it takes where this child's not going to feel so separated and lonely. The family is also bothered by this. We've got families that are coming in and out of the hospitals. They've got other children that can't get to the PTA meetings. They can't get to their award giving things because their brother, their sister is in the hospital. And remember, the kids at home also are going through something during these prolonged mobilizations. Now, what I liked about where I worked in a pediatric facility is every unit was a certain diagnosis. You had the cardiac floor, the respiratory floor, we had the cancer floor, we had the neuro floor. And in them, they individually had parent groups. So you had a cardiac parent group, or you had a neuro or a cancer parent group. And those parents go and they verbalize their feelings, share what's going on, and actually share good things like where they got products or things or somebody helped them that could benefit the others. Parent groups are amazing and they work wonderfully. And then, of course, individual if it's needed. So now let's go into these injuries. Kids, they are always running, jumping, falling, bumping, hitting, and always doing something. They're always active. We know traumatic injuries, it could just be normal play or, of course, sports, because we know children love competition. Now, contusion is damage to soft tissue. We could call it ecchymosis, a bruising area. It could be from a crest injury. It does cause swelling, pain, and sometimes it hurts so much you can't walk on it. The one thing I'm going to warn you about looking at an ecchymotic area, the outside may not look that swollen. Remember, it could be underneath the tissue that vessels are occluded, blood flow isn't going. So neurovascular checks, very important, distally of these bruising. So if you bruise on the calf, you're going to check neurovasculars in the toe. If it's on the arm, you're going to the fingers, okay? Important, you don't know, so always be safe. Now, dislocation. All right, here's another Downs problem. The poor Downs children, right? They can get leukemia, thyroid problems, congenital heart defects, and they also have this potential of dislocating their hips because they're so extremely flexible. I don't know if you've ever been in close proximity of children with Down syndromes, but they are extremely flexible. Both feet can go over their head easily, and it's not a stretch. You don't have to push it. Me, I'm lucky if I get them straight up in the air, right? Problem with this is sometimes those hips pop out, the femurs pop out of joint. So we shouldn't, promote that. We would say, no, that's okay. Let's put your legs down. With hip location, we know it's always that problem of maybe it's going to have that lack of blood supply. And of course, death of tissue. And now you have more problems with the hip and the femur head. Now we have sprains and strains. Sprains, I think we've all stepped on a pebble, rolled our ankle, fell on the ground, and oop, that hurt. I mean, I've done it in sports. Volleyball was the big one. Go up, spike a ball, come down, land on the ankle, and you hear it crunch. So all of my weight on the ankle crunching. And what happens is those ligaments are torn, they're stretched, little blood vessels pop, so you're going to have this bleeding inside the joints or the skin, and you're going to have the nerves irritated and swelling, and it does hurt, and it's quick. I know that when I would get a sprain, playing, whatever, I knew the first thing to do was to sit down, and put my leg straight up in the air and wait for the coach, because that will decrease the swelling, because it would swell within seconds. You could feel it. And I learned, because I've done it more than once. And then, of course, we put ice on it, we wrap it and elevate it, which is a big thing. Strains are something that happens over time where you're using the same skeletal group and over repeated. You see this with people who are training for Olympics, runners, gymnasts, using those muscles, but over time, and it hurts. So with these, what do we do? I just told you, get a sprain. What did I do? I sat down right away. That's my rest. And then ice. Ice constricts the blood vessel, decreases the amount of bleeding going on, and then put an ace bandage on it. And the elevation of the extremity, again, keeps the swelling at a minimal. It's still going to swell, but not as much. Years ago, I've had bad sprains. Never, ever, ever did I get a splint or anything or a cast. They just wrapped it in ace bandage, gave you crutches, and told you no weight bearing for whatever days, and then, partial weight bearing. Today, they feel that putting either a really bad sprains, casts, or splints immobilizes it and allows for healing a lot better. So today, they've learned, change in practice, that casts and splints are better for these. Nail fractures. I mean, look at that little boy. Bilateral fractures of the wrists. Most common is the wrist on children. You fall, your hands come out, right? And your wrists are there. A couple years back, the hoverboards came to town for Christmas, and I'll never forget them because it was in December and they're out on break, and two specific little boys came in. They were 10 and 12 years old, and bilateral fractured wrists, and both bones, both wrists fell off the hoverboard, arms came down, and he ended up in two casts, both of these children. Now, what if you have an infant that has a broken bone? What would you think? Should infants get a broken bone easily? You see broken bones in children, it would have to be done very forcefully. Remember, I told you, even like the head comes out and it's not shaped right. And just tummy time a little bit, keeping it up will make that head go round and stop that flat from going on. Bones are so soft and malleable that to break it, it has to be very forceful. Now, I have seen an infant that did have, it was abuse, and it was a 3-month-old infant that came in with a yellow, green, purplish mark behind the left ear. And the mother was crying, and the registration desk said, "Could you please take this lady? She seems so upset," because the place was crazy busy. Sure, an infant, yes, bring her in. When I went to pick up this baby out of the mother's arms, my fingers went into the scalp. And I'm like, right where that bruising was. And I did it very gently, because what do you do first? You weigh children so you can give medications properly, right? Every child all get weights. Infants get weights, older children, height and weights. So when I felt that, I knew what had gone on. And I know that possibilities, mom didn't have any answer why. Um, so I went to the doctor and the charge nurse and notified them my feelings, which is what your job is. You want to suspect any type of abuse, you need to tell your supervisor. And of course, we did have a head doctor on, and I went to him. What we did is we took this infant over, I did myself, over to X-ray, and we did an X-ray of his head, and we saw a depressed fracture of the skull. It was so obvious. We did an X-ray of the body. We found fractured humerus, fractured ribs, and a fractured femur. This is all on a 3-month-old infant. The mother apparently had worked a lot, and daddy had lost his job. And daddy was taking care of not only this infant, but his twin brother and the 2-year-old kid. And he got frustrated, and the kid wouldn't stop crying, and his head apparently hit the surround in a shower. And what the other things and how it happened, I don't know. But the end result and what you need to focus on, because, any person would like to scream and yell at this mother. It wasn't the mother, it was, the father. And today, these infants are safe because we did our job as nurses. We took care of the children, and it was all three children had signs of abuse because we brought them all in and looked at it. So, abuse, not nice. And it hurts my heart till today. I still think about these little kids, but I know I did a right thing. And that's what you focus on, okay? Now, types of fractures. Most of them are simple. They break, they're under the skin, you put a cast on, make sure their bones are straight, etc. Now, there are times where the skin is open and the bone comes through, or the skin is open, you can see the bone. It's just open. Problem with this is it's gone. Now the inside of your body has touched the atmosphere and all the germs and bacteria that are there. Your goal in a fracture of like this is to start antibiotics as soon as you can. We don't want to cause osteomyelitis on these children. So these children, of course, will do an X-ray, of always checking neurovascular signs, and as soon as we can get some IV antibiotics. Many times these children are kept in for a day or two to get that IV antibiotics, and some are sent home on IV antibiotics. We'll put in like a PICC line on them. So we worry about that. So open or compound IV antibiotics. We have complicated or comminuted type fractures. These are little fragments that can go hurt other organs. For instance, the ribs can go and puncture lungs. Comminuted little pieces and fractures are in there, these little sharp edges hurting the muscles and nerves, and it's extremely painful. And then we have something called an avulsion. The bone is just ripped away from the tendon, and again, extremely painful. Now, the one time we get really concerned about fractures is wherein a child falls and fractures an epiphyseal plate, which is the growth plate. The growth plate is where bones grow so a child gets taller. So these fractures must be on line completely. You don't want it crooked, or else you'll have a crooked arm, or a shorter arm, or a shorter leg, or a crooked leg. And you don't want that. So these children, you hear growth plate fracture, they're going to the OR. Open reduction internal fixation to line the pieces up perfectly so that we have a child who grows the right way. Epiphyseal plate, growth plate. Now look at this, and I'll tell you why this is important to know. Neonatal period is the first 28 days of life. 2 to 3 weeks, we can heal a bone. What if they come out with fractured clavicles? It happens all the time at birth. They'll heal in 2 to 3 weeks. Another thing that we're going to talk about is club feet. Club feet, crooked, whichever way they are, we can put them in serial casting and we can get them pretty well where we want them within that period of time. Can you imagine? Because they're so moldable and bendable. Now, the young kids, 4 weeks in a cast, and then usually between 4 to 6 weeks is all children need in order to fractured arm, fractured leg, and we could take casts off. They heal quick. Now, adolescence is getting more, and I know if you put me in a cast, it's going to be 6 months. It's just not going to heal. But that's the difference of age. Young kids are resilient. So the quicker we get those club foot casting going on, the quicker we can get that foot the way that we want and that ankle. Okay, so fractures. Fractures are the child comes in. What are you going to see? Well, a child that doesn't want to walk or put any pressure on a leg that's been hurt probably is fractured. Usually sprains, strains, you're able to touch the floor. Fractures, no. What are we going to do? Well, Of course, an x-ray is going to tell you. We're going to ask the parents. They're going to tell us what they say happens. And we're also going to try to get that child alone and ask them, just to make sure, again, we are children's advocates. We want to make sure that nothing happens to any child in our care. I can't emphasize that enough. I've seen enough of it. So goals are, we want to reduce it, keep it mobile, and we want the function to be good, and we don't want to crook it, right? We don't want any shorter legs. We want things to be back to where it was before it was broken. Now you put a cast on a child. These are things that you need to know, but also the child and whoever the caregiver is also need to know. Now, that picture on the bottom right is extreme. But can you imagine having a long arm cast on and then nobody looked at it for 2 months, a month, how many weeks? I don't know how long it would take to get there. But the possibility is, my point is, it can turn fingers gangrenous. It can cause loss of fingers and limb. So neurovascular signs, blood supply going to the fingertips or the toes is what we're looking for. So pain, what is the pain? Is it getting worse or is it getting less? Pallor, is it getting blood supply or is it not? What's the capillary refill? Pulselessness, if you're able to feel a pulse. Paresthesia, that numbness, that tingling, it should not be numbing and tingling. It should be, normal sensation. Of course, if you can't move it, and then the pressure, compartmental syndrome going on. We need to let those parents know if they're seeing things to the extreme that they do need to get back in. And many times we have to either cut the cast off or put a hole in it or do something so that we get the blood supply back to that child. In pediatrics, we do have a lot of those uh, people who orthotechs for just children, and they think about casting children is a big deal, and they do have to manipulate the arm or the leg in order to get the cast correct. But what if you gave that child a choice of colors to put on their favorite sports team, or it's Christmas and it's green and red, or it's Easter pink for the girls? If you can distract the severity of putting the cast on and that little pain he might have, isn't that pretty neat? Because putting a white cast on is not exciting. So we had army casts, we had rainbow casts, we had yellow, light pink, light blue, dark blue. I could go on and on. Now, they didn't have all of them all at the same time, but an extremely good variety. So I used to pump the kids up for what colors they were going to get. And that would, again, take their mind off of it. Also, taking care of the cast at home. One of the biggest things is putting things inside, lotion, powder, or jumping in a swimming pool with a cast on, or getting in the shower and not protecting it. I've told this story several times, but there was a little boy, I don't know how old he was, 7, maybe 8, got a short arm cast, went home and jumped immediately in the pool. And the mother brought him right back in. Of course, had to go through the process of waiting through because there was a lot of kids there. Gets another cast on, sent him home. 2 days later, I see the kid again. He did it again. And we told the kid if he did it again, whatever the consequences were. But they didn't understand getting it wet, it could build algae and bacteria and, create more problems. So we send them home with all these plastic bags, whether it be short arm, long arm, small, medium, large, long leg, short leg. There's all different sort of casting things that we do and give them, and all of these instructions. Many of them do follow up with orthopedics, and they take the cast off, as I said, 4, 6 weeks, 8 weeks is the absolute maximum. And again, that skincare, just a nice cool hair dryer is the best. No little sticking sticks down there and pencils down there and hangers that can only cause damage. So traction, we when we use traction, most of the times it's for the fractured femur. I've really not seen it in any other cases. Maybe a fractured hip, and we might even bilateral them just to keep everything straight and from moving. But mostly we use these for fractured femurs. And the reason is because those muscles will pull the edges into the nerves, into the muscles, and it hurts. So we pull this butt traction and it pulls those bones so that they're held like this until we can do surgery. And they put a rod up actually the middle of the bone. That's how they do it today. They didn't do that years ago. We put a pin and they were in the hospital for a month. We don't do that anymore. We'll put them in butts, get them to the OR, put the rod in, get them through physical therapy, rehab, and they do well. Now, how do we take care of this traction? Number one, there is a rope and a pulley and a weight, and 5 pounds, 2 pounds, depending on the child. So document that weight every shift. That's showing you you're giving a proper treatment. Also, check neurovascular signs every time you walk in that door, right? This must be on 24 hours a day. You can't take it off. If you take it off, that bones are going to separate, and now you're in severe pain again. And you don't want to do that to the child. And then that bones have to be manipulated to get back. So a lot of pain. You don't want that. Now, traction is to leave those muscles from spasming and causing pains. We know it's to prevent that deformity. And we have different sort of tractions. Now, the one on the left, I'm going to mention it later in a neck thing, but that is a halo traction. And I'm going to describe a boy in a second. This other one that's sitting up with that halo traction thing, many times there's surgeries done on the first two vertebrae. It's this Kahari syndrome, where something with the blood supply, and they have to do surgery, and they stick them in these things and keep their neck straight. So it's an open fixator device. It's on the outside. So types of traction. What do you need to know about these things? Well, we know Bryant's, we know to check the weights, we know it never comes off, and neurovascular signs. The one below it, Russell's, is just like Buck's, but has an extra piece to hold right where the femur is. It's a choice. The other one you need to know is that bottom right one, and that's Bryant's traction. This is again where that Havlik harness and that spica cast not working. Maybe they went this way instead of a spica cast. And this is Bryant's traction. The child can't be over 30 pounds. That's the first thing. Then your hips are up a little bit and it's at a right angle. And that's the way they are. And it hopefully will pull and put those hips back where they need to go. All right. Another thing is an external fixation device, like the one I told you. Here's some more. Now, why would we use these things? Well, sometimes it's severe, multiple breaks in a bone, and they want to just position it and try to give that body a chance to make its own bone and line up and fix the whole bone itself. Sometimes you have a short leg or a short arm, I've seen it actually, where they can break the bones and make them bigger and they'll grow and you can get an inch or two more height out of these children. I actually, which is crazy, but my physician had his short legs and he was bow-legged. And at age 50, he went out and had bilateral of these things. And he said it was the worst thing he's ever done in his life. He said it was extremely painful and very cumbersome. Can you imagine this thing on the bottom of the leg? So when children want to do this, remember, number one, as they first get it, it's all about pain control. The second thing, and you can see it, preventing infections. All of those pin insertion spots. How do you take care of them? The way the doctor tells you. There's always some like peroxide, some like soap and water, some like this, some like that. It's whatever that doctor wants. Now, sometimes children are born without limbs. Could be a finger, could be a hand, could be a foot, could be a leg. It's all different things that can happen. Also, you know that sometimes children lose limbs for a various amount of reasons, whether it was traumatic loss or we had to take it off. Now, I did have a friend whose daughter, I met her at age 5, and she was born without a fibula. She had a tibia, but she didn't have a fibula, lower leg. So at birth, there was no bone they could put there, prosthesis. They had to do a below the knee amputation and gave her a prosthesis. Well, this little girl met me and my 2 children when she was 5 years old. That little girl came over to my house, got comfortable, took off her leg, and chased all the kids around the house with her prosthesis and was going to beat them over the head, up and down stairs, moving more than most kids do with both legs. So don't feel sorry for her. That little girl got spunk and vinegar, and I loved it. Remember with the amputation, like that, if we have to take legs off for whatever reason, remember, just like adults, that phantom pain and treating that pain, and then making sure the prosthesis and they're using them properly and they don't get any abrasions, and so that they can use and be able to be quote normal children, right? Now, sports. Children love sports. They like to go out there. They like to be rough and tumble. And the problem with sports a lot of times is that competitiveness makes children get these overload injuries because they keep going, 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 going. They don't want to stop because they want to win. They don't stop to drink. They don't stop to stretch. They don't stretch before they go, and it causes injuries. One of the things we can do and help is, of course, those stretching before they go out and they exercise and proper equipment. Giving them, making sure they have proper shoes or protective devices, helmets, shoulder pads, or whatever they need, knee pads. Make sure they have it. Overuse syndromes, it's because kids want to be the best they can be. We see that a lot, as I said, in gymnastics, track, those things. They are pushing themselves over and over and over and over and over again, and using again some of those muscles can cause an overuse. So here's that developmental dysplasia of the hip. We started out with the Pavlik harness on the first page. Well, this is what we're talking about. It's more in girls than it's boys. And if somebody in the family has had it, it's a possibility another child in the family can have it. So it's sort of inherited, but it's not like a genetic marker. It's just usually it will happen. Now, when a baby is born, we don't know is their hip there or not. We go to the doctor. And the doctor, what does the doctor do first? They, of course, do their assessment. And one of the things they do is put the knees up and down and out. And they're listening for clicking, and they're seeing if those hip joints are where they should be. Then they turn the child over and they look at the buttocks, the gluteal folds. Now, in a hip dysplasia, the femur head should be in the hip socket. Well, it's up here. From here up to here, whatever the stage is. And our goal is to pull it down and stick it back in. All right. So the hip is not in socket. So that leg is going to be shorter. And the gluteal folds, you're going to see the difference. And you're going to hear this clicking going on. That positive Ortolani, that positive Barlow test, you're going to see those things. Those are your signs. So, as I said, first thing we're going to do, remember, first 2 to 3 weeks of their life, they can like heal a lot of things because of their bones being so soft and malleable and moldable. Get them in that Pavlik harness. You put that on that child. If they notice this in a hospital, we can get it on the same day or the next day, right? Get them in that harness. And how do we take care of that harness? 23 hours a day. You take it only for bathing and to inspect underneath the harness, making sure there's no irritation. There should be a cotton t-shirt underneath for that rubbing because their legs move and it does pull on the areas around them on that harness. And it's in an abduction. You need to know that abduction of the hip. So it pulls it where it needs to be. Older children, like I said, might be in that Bryant traction if it's not gone in where it should, or maybe a spica cast. And I showed you that picture. Now, I've never seen it, but it can be so severe and those so resistant to movement, they might have to cut tendons to get the hip joint back into where it needs to go. And that's usually a couple years old. Now, I mentioned club feet and I mentioned casting because we see this at birth right away. Now, there's four different sort of club foot. You don't have to know them. All you need to know is babies can be born, their ankles and their feet could be in any different angle. And that's what that's telling you. So, how do we treat it? Well, as I said, this is serial casting. And what we do is we try to place that ankle and foot in proper position. And this must be changed every week. Every cast, every week. Well, bones heal how quick in neonates? This is placed on neonates. So we want it on as quick as possible. They heal quick. So we're changing it every week. It might take 6 weeks. It might take, 4 weeks because these children moldable because they're neonates. That's why we got to get it on quick. Now that serial casting is called a Ponseti method. Now, these children, we're going to be doing an every week a cast change on them. As they get older, they still need follow up with the podiatrist, the orthopedic, for their ankles, just to make sure they might need different shoes or something in order to keep their ankle and that club foot, keep it in proper positioning. Now, I mentioned osteogenesis imperfecta, OI. This is one of those congenital brittle bone diseases. This child scares me, and not many children scare me. You to put your hands up underneath and to lift just to change a diaper, I'm always concerned I could break a bone, and that's how fragile they are. I would always take baby blanket underneath and I'd pick up a baby blanket to get underneath them so that I wouldn't be touching or squeezing anything inadvertently. These children, this is no cure. There is really nothing we can do. And it's basically supportive. The thing with osteogenesis imperfecta, you can go from severe to milder cases. I've actually seen documentaries on families that were almost prosecuted for child abuse because that's what it looks like. Children, babies coming in with broken bones. Remember, we report those. So these children, broken bones, babies, they have osteogenesis imperfecta, was not diagnosed yet. And they were saying, you're child abuse. And the parents are like, no, I'm not. I want my child back because they take the child away. Okay. We might give some biphosphonate therapy. And again, our goal with these children is to maintain their bodies so that we can put them in a functional position, like getting out of bed, getting them in wheelchairs. These children have electric wheelchairs, and these would be the ones that would be behind you going to the cafeteria. You'd be walking in front of them, and you hear this little kid going beep, 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 or they had a bell and they'd be ringing. And I would always smile to think they're so alert, they're so smart, in these little electric wheelchairs, and they're tiny little, usually very, small, petite stature. But they're fine. Now, here we are with another femoral head problem. Okay. So we have DDH. We have leg calf birth. Leg calf birth is aseptic necrosis of the femoral head. So there's no infection, but all of a sudden the blood stops going to the femoral head and it dies. And it's painful. Usually what happens is all of a sudden these children are limping and complaining of pain. And then they go and they do x-rays on them. Um, and it's usually like when they're sitting for a while or, bed in the morning when they get up, the stiffness and stuff goes on. So they do the x-ray and they find it. And what do we do? Well, usually the x-rays is a fuzz over the area. Usually it's even cancer infections, like this little fuzz you're going to see on the heads of the femur. You can see a slight little darkened line on the left one. Our goal is to protect the head of that femur. We don't want that to be dissolved and go away. So our goal is we need to put this child on bed rest. We have no weight bearing, so no physical therapy on that leg, right? We're going to give NSAIDs. These are anti-inflammatory, decrease inflammation for pain, and it works. Sometimes they need surgery. Many a times these children go home on Buckstraction. And our biggest goal with anything orthopedic is making sure that they get good nutrition, good protein, good calcium, good vitamin D for healing for all their bones, okay? Now I'm going to go into 3 different conditions. They're all spines, and one is kyphosis. I actually call this humpback. It's when your upper goes over and you sort of lean forward. It's called kyphosis. Lordosis, I'm going to go into condition in a little bit. That lordosis is one of the symptoms of it, but it's an inward curvature of the lumbar spine. So the upper body sort of leans back type thing. Sometimes children who have this, it's something that has to do with congenital. This could have been a congenital hip that happened. And sometimes body fat, is where's the body? They get stumbly because of this, the way that their spine is. And then the extra fat is like trying to find their gravity, their how to, stand up without falling over. Scoliosis, most tested item, I would say, is scoliosis. This is an S-shaped curvature of the spine. This usually you see it when they're younger, but it's that pre-adolescent growth spurt, that 12 to 14-year-old, when all of a sudden their body grows 20 to 25% of their total height at that time. And when they're growing that quickly, their spine's curved. Now, why, and what do you see? Well, as I said, it's usually with that big growth spurt, and all of a sudden you're going to see one shoulder higher than the other. So an arm will be dropped. Sometimes you see the hips crooked, and all of a sudden you can see this shape from the back, something going on. Now, they used to do some school screening. They don't anymore. I don't know all of the ins and outs and the why. It was just, part of the book that I saw there. But I think school would be a part that could see those things. Now, how do we take care of this big curve? Because this is the one that's the most concerning, the one that you need to do treatment for, because we can correct almost the whole scoliosis. I mean, there's still going to be residual S-shaped, but it can be decreased. Now, less than 45 degrees, let's put it to 45. Less than 45 degrees, we're going to be doing a brace. Now, this brace, again, 23 hours a day, a cotton shirt underneath, no lotions, no powders, and then you put the brace on over it. So 23 hours a day, brace. And these children also will be getting physical therapy to strengthen their core muscles so that it can straighten up that spine. Now, after that 45 degrees, which means you're really now compressing the lungs a lot. Think about the upper spine, thoracic spine. Your lungs are right here. It's pushing. So it's closing up space so the lungs can't expand and breathe the way they should. So they've got to straighten up that spine. But greater than 45, it needs surgery. I mean, 45 and under, 40 to 45 is debatable, but at 45, they need surgery. That what they do is they put these Harrington rods, and it's these two metal bars on each side of the spine, and they connect to the spine. And they can take a big S and make it less of an S. It's not going to be completely gone, but it can straighten it up as much as possible. One of the things that you learned in either health assessment or fundamental was log rolling, right? This is the patient that must be log rolled. Pillow between the legs, one motion over. There's two metal rods in the back. You don't want to by being crooked when you roll them. Osteomyelitis, I've mentioned it and the reasons and why it can happen. Most of the time, believe it or not, osteomyelitis in children are in the feet because they're walking around with no shoes on. And what would you see? Well, it's going to start with pain and redness and swelling and heat, and then it's going to go systemic, and now you have a fever, and you're going to be able to see that redness and that swelling on now. We're going to do x-rays. We might see that little fuzz, like I say, that you see in infections. But bone scan is like that. The radioisotype goes poof, right to where that bone is inflamed. So osteomyelitis, this is dangerous. We've got an infection going in the body, and it's most likely staph. What do we know about any antibiotic used for staph? It's probably an aminoglycoside, vancomycin, which means peak and trough levels. Peak measures how big the dose is, and the trough tells you how long between doses you need to wait to give the next dose, so you're not having too much in the system and making that child toxic. So during this, well, absolutely, aminoglycoside side effects, ototoxicity, renal toxicity. We'll be monitoring hearing. We'll be monitoring urine output. We'll be monitoring all of the blood, hematologic, renal, hepatic, excretion, absorption. All of these things we watch very closely. This child also needs to be on complete bed rest. We don't want this to be breaking off an infection everywhere. And then it's that long-term antibiotic. And this is 3 to 4 weeks. It could be 6 months. There are resistant ones, so depending. And again, diet. Again, you'll always see diet. High protein. You want your vitamin Ds. You want to have your calcium. Now, Ewing sarcoma, I mentioned it. It's cancer of a bone. Could be a jaw, could be a scapula. It's basically the same sort of treatment that we do with any type of tumor. It's radiation to shrink it, chemo, again, to try to keep it shrinking. And if we can, take it out. But if it's the hip bone, can we, depending on where it's at, can we take a scapula out? Depending. So again, the prognosis is where it's at and if there's no metastasis. Now, juvenile idiopathic arthritis. I think because I have the adult version, one of the hardest things to diagnose. You have a child, ages 1 to 3. That's your big ages for usually when we do diagnosis of children or juvenile idiopathic arthritis. And what we're going to see is a child who's something's going on. Could be environmental, could be emotional, because all of those things can trigger it. And all of a sudden they start things like, again, joints don't move, they become stiff. So to get up in the morning, you have to stand there for a second. And you got to do a little bit of wiggling and a little bit of moving to get the hips and whatnot moving. Children do this. You're going to have some difficulty walking. It's more like you waddle in the morning because you are so stiff. You might limp where the pain is. And we know JIA is the body's attacking joints. Now, do you know there's a joint in the voice box? You hear my voice scratchy? That is the rheumatoid arthritis. I've actually gotten even to the point where I can barely talk. There is a joint in your voice box. I had to teach my rheumatologist that one. And the other thing is uveitis. You've got to have them go for um, yearly eye exams, to look at their eyes, making sure we're not getting that. Now, there is no definitive test. Usually it's symptoms. And for me, they're like, yeah, you're fibromyalgia. And I'm like, no, I'm not. And I kept saying, no, I'm not. And I went to 4 or 5 different physicians. And sometimes that's what it takes. Because sometimes you see elevated SED rates, sometimes you don't. Sometimes you see that ANA is positive, and sometimes they're negative. And sometimes you have a RA positive, and sometimes it's negative. It all depends. So trying to depict it is difficult, and it's a trial and error, believe it or not. You have a classic, and if they're showing you everything, you'll have an elevated SED rate. You'll have an elevated CRP, C-reactive protein. That shows an inflammation. You see elevated white counts. And there's one test that finally, they believed me when they got the results back. And it's a newer test called a CCCP. Now, the highest level it should be is 50. My level was greater than 250. So finally, the doctor says, I think you're right here. I'm like, are you going to listen to me now? I'm serious. I did just like that to him. So, what is our goal? Rheumatoid arthritis does not have a cure. You got to live with it. So, preserve function, prevent deformities. And if I have a day where I can move and I'm not in that much pain, I'm a happy camper. But what do we do and how do we take care of this? Well, NSAIDs are the drug perfect anti-inflammatory. And then those slow-acting anti-rheumatic. We've all heard of Humira. That's probably the most common of all, Humira and Enbrel. And then there's all sorts of infusions, Remicade, Orencia, Actemra. I've been on all of them. And you just got to find what works the best with it. And it's in combination with methotrexate. Methotrexate can be injections, sub-Q injections once a week, or it can be oral once a week. This all depends. And then corticosteroids are only a Band-Aid when you are hurting really bad. You can't be on just a continuous steroids because it's going to cause Cushing's disease, right? Too much steroids, too long. That's what happens. How do we care for this? Well, you got to keep the joints moving. You got to prevent deformities. So physical therapy, making sure that your pain is under control. If it's hot packs, cold packs, whatever you like. Most people love heat. Don't put heat on me. I want a cold pack. So I have learned to ask, do you like heat or do you like cold? Again, making sure they eat right, that they're active. Swimming is probably one of the best exercises. And it's what I do all the time because you're weightless and you're moving and you're having fun. Kids are distracted, so it's perfect for them. Now, lupus is when they start attacking all of the organs. So JIA is joints, lupus is the organs. It's usually female and that, young adolescents to the older adolescents, and it happens more common in African American, Asian, Hispanic. It's probably that menses that's being started, puberty, that hormone that's going on there. But it could be due to other stuff, emotions and stress and infections. And I think for me, who live in South Florida, exposure to sunlight can cause a trigger to lupus. Yes. Most thing that you can protect is that. So what do we see? Well, lupus attacks the skin, and that's why the butterfly rash. We can have nausea, vomiting, diarrhea. This is all GI stuff going on. It also can look like a little bit of arthritis. and joint pain because that is going to be there. But it's the stiffness, but it doesn't get disfigured like the rheumatoid does. And then it goes to the brain, and it's that forgetful seizures paralysis, and it goes to the lungs, to the heart, and it could go to the kidneys. So goal of treatment. Well, we want to prevent these children from getting any sort of flares, monitoring them closely, of course, and then, of course, keep them out of the sun and put sunscreen on them. So Kristen, 10 years old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, what the nurse should consider. What is that?
B.
It is a growth plate. Yes, it's bone growth. Again, make sure it's straight and it's going to be a surgery. A lot of those are elbows because you fall down and bang on the elbow. Okay, let's go into neuromuscular, muscular skeletal. I always think of this, I always think of cerebral palsy. Neuromuscular, I think of cerebral palsy children. This is a permanent disorder, and it's about movements and postures. And we don't know why. It happens. Um, it affects children premature, have hypoxic, anoxic episodes, and sometimes some sort of illnesses, infections. But many of these children with cerebral palsy end up with epilepsy. Remember, epilepsy and all the things to do with that, and monitoring them and the medications and good dental care and whatnot. So these children require a lot of care. This is, what they think the causes are. Well, the brain wasn't formed correct. There's some sort of blood occlusion that blood didn't go where it needed to go. It's some sort of the movement's not the way, low birth weights. One of the things with low birth weights and being in that newborn ICU is preventing interventricular hemorrhages. Babies' brains are very fragile. I mentioned that last week when we talked about GI and GU and how we don't give dialysis because their brains are so fragile. Well, again, just normally without any flow of anything, loud noises and jostling them can cause, believe it or not, brain bleeds. So that can cause cerebral palsy. And then, as I said, any anoxic hypoxic episode. When we think of cerebral palsy, the one that we think of is the more severe, that spastic cerebral palsy. And we say that is hypertonicity, poor posture, and difficulty maintaining balance. These children are going to need help walking. They might need walkers. They might need wheelchairs. They not be able to walk at all. If they're, sitting, they might need to have a harness, a seatbelt on, and some things to help them, maybe canes or something to help them walk. Usually walkers that they'll put them on. Cerebral palsy is checking and doing testings, and that's mostly for parents to see if there's other things that are going on. Children with cerebral palsy, they've had a brain insult for some reason, okay? So delayed gross motor development, cognition is going to be down because of this brain insult. So abnormal motor performance, which means that repetitive behaviors of, just not being able to move themselves without all this stiffness. Abnormal postures. That's why we're going to put them in seatbelts, making sure that they're not falling out of chairs, etc. And their reflexes are going to be different. What is our goal with children with cerebral palsy? Well, the answer is for them to be the best they can be. Years ago, when I was a teenager, I used to not work, I volunteered at and this is a really crazy name to say back in the early 1970s, but it was the Association for Retarded Children. Back in 1970s, that was the name of the association. We don't say that anymore. We've learned we don't want to put names and stigma, But I used to work with these children, Down's children, cerebral palsy, and I've learned so much from them. And back then, do you know how we treated them? We did custodial care. We fed them, we changed them, we got them out of bed, we put them back to bed, put them in front of a TV, maybe did some games to make them laugh or something, but we didn't do one-to-one attention. Now, today, for instance, when I was doing clinicals for Fortis, went to this one pediatric extended daycare, and my little Jonathan, nonverbal CP guy, and you would look at him and think he had no clue what was going on in the world. But they gave him a pad where he could communicate. And at 7 years old, when I met him, he was learning letters and numbers and shapes and colors. They didn't do this. But my point is, in 1972, when I was doing this, they didn't do it. They did custodial care. So that's why I say my goal is to be the best they can be. And once they get there, make new goals because they will surprise you, even nonverbal. Okay. We want to give them the ability to be able to move, communicate. Jonathan, without that, wouldn't be communicating, right? You know, doing the best he can do a lot for himself, but, he could express himself and he really had a cute sense of humor. And I think this little boy down here is happy because he can move around on his bicycle. And what is he doing? He's getting exercise. So prognosis of cerebral palsy, it depends on the level of cognition delay, right? Remember, sometimes if they're really severe, we've got to make plans for the really far future for those children. And sometimes nurses can direct them to the social workers to help them, right? Also, these children they're not going to quote get better. There's no cure. So let's teach parents and let's teach the family members how to take care of them, how to give medications, how to be safe, how to have fun with these children. I mean, one day we took pools, little baby pools, and put them all up in the backyard and had some kids in it and some kids' feet in it and splashing them. These are CP nonverbal kids splashing in a pool with smiles from ear to ear. And you wouldn't think, but that's fun. You got to give them that recreational activity. They're still children. And then, of course, the number one, early interventions, speech, physical, occupational therapy, keep their bodies moving and give them a way to communicate. And then always be that big hug for the families. Now, neural tube deficits is something that you heard of in pharmacology, and it was all about giving folic acid. You should take it starting a month before you want to be pregnant. All right. Well, this is what a neural tube deficit is. It's when the spinal cord and the meninges that's covering a spinal cord and the nerves from the bottom of the body are ripped up and are on the outside of the low back. And it looks like that blob. And they're born that way. Those are the different names of them. It could be due to that folic acid thing, or it could be due to some, maternal things. Now, what is your job? What do you need to know about that? How can you take care of it? Well, these children will not be placed on their back. They will not be swaddled. They'll be placed in a warmer because we need to see it. When they get to the unit and they're coming, you should have normal saline, sterile at the bedside, and sterile dressings. We want to keep it from getting infected and maintain the skin integrity around that thing. Okay. Now, because it was pulled up from the bottom and then put on the outside, nerve damage is going to be there from mild to severe, which means sensory motor. They could move or not move or partially move. You don't know. The one thing about these children, because they will have multiple surgeries, and they found that these kids got latex allergies, that immediately at birth, we don't put any latex on these children. We just don't. It's just one of those we've learned, why try? So we just don't. Now, because of this nerve pulling, and that blob of nerves and meninges and spinal cord there. You got to really monitor urine and bowel. These children, many of them end up being catheterized every 4 hours because they don't have sensation. Again, there's a folic acid neural tube deficit. Put it in there for you. All right. Spinal muscular atrophy type 1 floppy infant syndrome. This is a child that lays like a frog and has progressive muscle weakness and skeletal weakness. These children never even lift their head. So, what do we usually see in an infant at birth? They don't move, right? Normal. Then all of a sudden, at 3 months, they're still acting like a newborn infant, not even holding their head up. This is a lot of the suspicion here. The infant lies like a frog, and then all of a sudden, you need a lot of muscles to, right? Well, these kids, because they don't have the muscles to push behind cries. So weak cough, weak cry, and of course, that weakness going on. These children die before their age 2. Muscle degeneration. What's your muscle? Hearts, diaphragm, muscles don't work. Now, this is the diagnosis that's on every test you'll ever see. I was told this by students. It's on NCLEX, it's on HESI, it's on your exam. Duchenne muscular dystrophy. It's the most severe and most common of all muscular dystrophies. And it comes from mommy. X-linked. It is males, age 3 to 7. So these children might have a little cognitive delays, but by 1 year old or shortly thereafter are walking and doing all those developmental steps that they should. And then you're going to see their calf muscles get big, almost like they've over exercised calf muscles. And now they're this big instead of, normal. And that's one thing you see. All of a sudden, these children that were walking are becoming muscle weakness. So they're starting to stumble, they're starting to fall down, right? They're starting to um, decrease their level of movement. Remember, they're still cognitively a little bit delayed. And it's muscle weakness that's progressive. So death from respiratory, cardiac, same thing. And it's usually about teenager that most of them last to. Now, how do we diagnose this Duchenne muscular dystrophy? Well, we see a child who was up to here, and now all of a sudden you see these muscles, then you see this stumbling and falling going on here. We're going to do something called an electromyography or an EMG. And what it is either little skin tabs or little tiny little needles they put into a nerve, and the machine, you hit it, it will give a spark, and you're going to see how well the muscle contracts with the spark that it got. So they do it all over the body. When they're done, it felt like they ran a marathon. They've spasmed all the muscles in their body. So when they come back and maybe for a day or two, they've exercised too much, like a day at the gym after 3 years, and how you feel and ache everywhere. Well, that's the way they feel. So give them some acetaminophen, ibuprofen, something for the discomfort, and let them know that it will go away. As I said, with all this muscle weakness, that waddling gait, those falls. Anybody know what a Gower sign is? The way I get up off a floor, I crawl up my legs as I stand up. So you get up and maybe on your knees, and then you put your hands on your thighs, and you just climb up. It's Gower sign. You climb up yourself in order to stand up because your muscle's so weak. I've had to do that for a few years now, getting a little older. And then, of course, the lordosis. Like I said, this is a diagnosis that has lordosis. So enlarged muscles, it's mostly thighs. Sometimes you see in the upper arms. And again, there's going to be some mental impairment, cognitive delays. And because they're not moving well, they're going to be a little bit obese. They're going to be heavier. So what's our goal? There's absolutely no cure. It's just giving them the amount of function for the amount of time we possibly can. right? That's all we can do with these children. We need to do them physical therapy and keep them moving and open and being able to live a normal type of quote life. And again, that mother and father do need genetic counseling because it is a genetic disease that came through, and every male is going to have Duchenne. Now, the other one neuromuscular is talking about, this is a disease where I've seen it usually after an upper respiratory, like 3 weeks after, 3, 4 weeks. And all of a sudden, the feet become a little numb and you don't feel them good. And you start shuffling and falling. And then the numbness goes to the legs. Now I'm becoming incontinent. I'm becoming constipated. And then it goes up a little bit more and says, okay, phrenic nerve, stop. And now you stop breathing. So, what is our biggest goal with Guillain-Barré? Respiratory, right? If you don't have airway, you got nothing else. So, you'll see all of that decreasing strength from the feet up, ascending, feet up, okay? And it can go pretty quick. Again, you as a nurse, if this child is not intubated yet, you'll be having that child in some sort of step down ICU minimum, and you'll be monitoring that vital signs and the O2 saturations. We give steroids and IVIG to these children and maybe some plasmapheresis. Sometimes that does help. Again, our goal here is all symptomatic. Breathe for the child, decrease the side effects, blood clots, and taking care of the lungs and atelectasis and muscle strength and all of that. All of those things we're still going to do. Again, it's all to prevent any of those complications. And then all of a sudden, how do you know that this child's getting better? And now we're going to go descending with symptoms. So you're on a ventilator, you don't breathe at all. Now, all of a sudden, you start to take breaths over what the ventilator is giving you. If the ventilator is giving you 12 breaths a minute, all of a sudden you're going to see it 16 breaths a minute, 20 breaths a minute. And you're like, okay, this child is waking up. We can turn the ventilator down slowly. Now, tetanus, lockjaw. This is when grandma says, oh, here's a little honey for your baby because they're constipated. Take a little bit and they'll move their bowels. You should never do that. And infants should never have any honey till after the age of 1 minimum. Some of the books say 2. So honey or Cairo syrup is one. Wait, that's the other one. Tetanus is they both do the same thing, is where they step on your rusty nail and now you've got an infection going into your body. The thing with tetanus and the other one that I'm going to talk about, botulism next, is all about rigidity. It's the swelling in the neck, going over, hitting the airway, and now you can't breathe from severe muscle spasms. So starts out with a little stiffness, and then it ends up with problems with the face and swelling. And now you know that this child is a tetanus. So usually, let's say it's on the foot. Remember, you still got to treat the wound on the foot. So that's one thing that nurses tend to forget. Soap, water, antibiotic ointment, and just to monitor it. That's part of it. The other part of it is to these children with all of this tense muscles and it hurts, we're going to put them on a really strong muscle relaxant to relax it. And we're going to be having them on a ventilator, and we're going to be given tetanus vaccine. Tetanus vaccine, we can, inject it around the wound. Sometimes I've seen that. And then giving this Tet-Tox. And sometimes these children come back. This is a very sick child. This is survival beyond 4 days, means they're going to make it, which means this child probably is going to go through quite a bit in those 4 days in order to make it through the other end. So how do we prevent it? Well, we get our tetanus shots, right? We clean wounds as soon as these things happen. And then sometimes if we need to go and get some globulin and put it around it and get booster depending on what it looks like. So it is intensive care. We're going to be monitoring, of course, fluid electrolyte, I and O, daily weights, electrolytes, absolutely. And we're going to be given the tetanus immune globulin therapy. And that's going to help cleaning that wound, soap and water, antibiotic ointment. And of course, those muscle spasms are so tight. These children, their muscles are going to be knocked out like they're going to the OR. They can't move. Muscle relaxants. Remember, muscle relaxants, their minds are still awake. Make sure they're on a sedative too, because they'll be wide awake and they can't move their body. And I think a kid would be really scared. Okay, botulism honey J-rose syrup. I apologize. This is something that we don't know if the honey, how was it produced? How was it handled? How old is it? It's a lot of, you know, buy of these, especially me in South Florida, buy this alongside the road. Now, for an adult, it's not as bad. But remember, kids, it's going to be very bad, especially under the age of 1. So, again, do you see the same sort of symptoms? Weakness, dizziness, headache. You're going to see double vision. You're going to have probably problems trying to talk. And then, of course, all of that goes on, and now you don't breathe. This child is going to be intubated again, getting the IV botulism immunoglobulins. And again, I didn't mention it with the other, but always remember nutrition, nutrition. You've got to have nutrition in order for these children to do well. Now, spinal cord injuries. Remember, I was going to say I was going to wait to here to talk to you about spinal cord injuries and some things. Well, I had a no, it was a 15-year-old boy come into the ER. I was the trauma nurse primary on duty, which means child comes in, I'm responsible. I'm making sure everything's there and I'm documenting. I'm in charge as the nurse. Okay. This little boy, 15-year-old, was playing baseball, slid into third base, his head hit the defender's knee, and the crowd heard a crack. Immediately, he couldn't move his right leg, and the left leg felt something. Somebody was there who knew what they were doing and immobilized that child immediately. Rescue came, helicopter to me, to my ER, and into my trauma room. So here I have this. It was 15 or 16-year-old, good-looking young man, right leg numb. Left side, he was tingly, but he sort of felt me down there. This is a C5, C6 angulated fracture, which means cervical spine. That means he could have been paralyzed all the way down. So let me just go over way things can happen. Well, it could be motor vehicle sports. That's that one. It could be pulling a baby out of a birth canal, or it could be in a car that back and forth. That's what that hyperflexion, hyperextension is, that coup de coup, one of those things. So that little child came to me, my 15-year-old boy, scared to death. My job was to be next to his head and talk to him and to make sure that there was proper immobilization. Because if that spine kinked, this kid was going to be paralyzed and maybe not even be able to breathe. It's C5, C6. It's a very up high. I'm talking, you could see like a little V on its side. It was that bad, and it should be straight. So immobilize it. And then during the whole time there, my job was to keep this poor child quiet. And I sent him through an MRI. And I was in charge of the head, making sure on my count, I took the head. I, made sure that we tried to rescue this child from being paralyzed. Well, I'll tell you the end of the story. 2 weeks later, I went up to the floor and he was being discharged the next day to rehab. His left leg was completely back, and there was some right leg was there, but it still had a little bit of tingling. But they said it was all going to come back. A year later, he found me in the ER and came up to me and hugged me, and he was perfect. And he jumped up and down, and you would have never even known that this kid had a C5, C6 angulated fracture. So if you don't think you make a difference, I'll tell you what, you do. So progressive infantile spinal muscular atrophy, that's your Werding Hoffman. I won't make you suffer on it, don't worry. So you like my stories? Who wants to win today? I think Daniel wants to win. I see. Yadeli's wants to win. And Ariana? Oh, Tammy, I see her. Oh, she's getting burnt. We're ready.
Dedicate up to 10 times the capacity for first responders.
I think there's 44. We'll be done probably right about 5 after, 10 after today. Not bad. Remember next week to try to come in a little bit early so we can set up on, yes, there will be class afterwards, and it's going to be a cahoots, and you're going to be okay with a cahoots. Because we're starting HESI prep. Winner, winner, chicken dinner. Anybody else coming? Okay, let's get going. Week 9. 2 more weeks is HESI. What is the priority for a nurse to assess following a cast application? Just remember the 6 P's, right? Pulses, pain, movement, and sensation, paresthesia, paralysis. Those are the P's for those. Just remember there's 6 P's. Okay. Patient teaching for a child with a fractured bone that has had a new cast applied. And the child may swim with a cast after it's been dried. Well, that little boy thought so. No. So our goal with cast is number 1, keep it dry. Don't put anything in there no matter what, not even powder or lotion, and it will it. It's one of the big things. Cool hair dryer does work. I mean, it's better than nothing. And of course, packing it in ice the first day is helpful also. What should the nurse monitor after a soft tissue injury? So we don't know really how extensive that soft tissue is, do we? We know if it's deep inside. That's why we do neurovascular checks, just to be sure that we do have blood flow into the fingertips or to the toes. A fracture that penetrates the skin is called. It is called a compound. Simple is when there's no open skin. It's usually the common one that we have, simples. Another multi. Bryant's traction. This is one of the things we use for developmental hip dysplasia, right? First, we start out with a Pavlik harness. Might go to Spica, we might go to a Bryant's. There's all different things that we can do to get those hips back in joint. And this Bryant's traction, your children has to be less than 30 pounds. The hips are up a little bit, and then the feet are at an angle, the right angle. And the big thing with that traction is to make sure that it's not rubbing. Again, no lotions, no powders, none of that stuff. And again, just making sure there's no breakdown. In any traction, you would do that. What is the priority nursing care of a child with a bone fracture? What's your priority? A compound fracture. So our priority is the IV antibiotics because we don't want osteomyelitis, because osteomyelitis is hard to treat. It could take up to how many months to treat it. So IV antibiotics are your priority. It doesn't mean I don't have pain medicine with me. Yes, I do, of course. And it doesn't mean I'm not checking neurovascular signs, but none of that matters if you go overwhelming sepsis and osteo. What is priority nursing care for a child who fell off a second floor balcony? And you're going to ask me if I've ever seen a child fall off a second floor. I've seen two. One did well and one didn't. So again, we have somebody who fell. Our biggest concern is spine, right? Of course, airway, yes, yes, yes. But keeping the spine is strict immobilization is one of our absolute priorities in that. Principles of managing soft tissue injury include I went up, fell down, and I sprained my ankle. So it's RICE, rest, ice, compress, and elevate. And remember, when we're doing that, to tell them the first thing is stick their foot right up in the air, right? Epiphyseal plate fractures in children may do what? So what this is worrisome is all about the growth of the bones. You could have a shorter leg or arm or a crooked leg or arm. So that's why these fractures are always done surgery, open reduction, internal fixation. Let's line up those bones perfectly. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? I think one of the things I've always done walking into any patient with traction, I go right to the tips of their fingers or toes, and I'm going to look at neurovasculars. I'm going to feel pulses, as I go in and say good morning, whoever it is, right? And if I don't feel a pulse, we're in trouble because now you're going to have that arm that looks black and necrotic because it can happen. Ugh. Die. How should the nurse care for a skeletal traction for a child with a fractured femur? So this Buck's traction thing, what are you going to do? Okay, the one thing that we're not going to do is we never touch the weight on it, and we never ever take it off. Because that fractured femur, we're holding that bone next to each other, so it's not being pulled by the muscles and creating all this pain. So you document that weight every shift. So it's like a treatment. My patient treatment is 10 pounds on their buckstruction. Also, it must be just hanging there. Leave it, and it's swinging. Never take it off. No people on the beds, all those sort of things. When caring for a 9-year-old in buckstraction, which action by the nurse is correct? So again, just checking neurovascular sign. And you don't want the bed up and down and doing all those things. It's just creating motion, and that could cause a lot of pain. And it could disrupt that fractured femur. What position do you put the legs of an infant with hip dysplasia? And it's abduction. Very good. Remember my name, Bogart, abduction. You might remember now. What statement by parents indicates more teaching regarding their 2-week-old infant with club feet? Remember, 2 weeks old, it's in that first neonatal period where bones do heal really quickly. So club feet. So treatment needs to be started as soon as we possibly can. And it's knowing that you're going to have to follow up with podiatrists, making sure the feet are working correctly so it doesn't get crooked again. And it's going to be every week that they get it, not every month. So what's wrong? Every month is too long. And now you've got this child with a foot in the wrong direction. Yes, Ariana. Where did she go?
My computer is messing up. I didn't raise my hand. I'm sorry.
Oh, okay. It's all right. Say hello anyway. Hello. All right, let's keep going. A multi. Osteogenesis imperfecta. OI. So remember I said earlier that our goal is to try to keep these children in a position where it's functional. If you look at that poor older person, they weren't taken care of like that. How can they get up, get in a wheelchair, get out, be, mobile? And that's what kids need. So again, it's brittle bones, and again, it's many times it looks like child abuse, but it is not. What is the pathologic cause of leg calf burst disease? So do you see, Christine, you see the fuzzy now? Nice and fuzzy. That's absolutely, I can see that's not right. So remember the thing about leg calf burst. It's the hip where blood stops going there, but it's not because of infection. So ischemic aseptic necrosis, that top of that hip ball joint starts to die. Kyphosis. It's a good old humpback. So that's the top of the spine that we're talking about. Another multi. Which assessment indicates an infant has developmental dysplasia of the hip? So the hip ain't where it should be. What do you see? What are you looking for? And I know the first thing I always see, especially a really severe one, is I'm going to see one leg shorter than the other for sure. And then it's those buttock folds, the gluteal folds, one's up, one's down, so you know, and positive Artelani. Moro is a startle, and Babinski is the bottom of the foot that splays, and that's for all age people. Lordosis is described as what? That's our Duchenne child, right? Duchenne muscular dystrophy. So this is that inward curvature of the lumbar spine. It's almost like they lean back on themselves. Scoliosis. My daughter's best friend as a adolescent had scoliosis and went through all of the braces and the exercises and whatnot. And it really did straighten up her back quite a bit. It is a spine and it's S-shaped, scoliosis, S. And remember that little curvature is pushing against lungs, so it does need to be fixed. Remember, it's 45 or less is going to be physical therapy brace. Above that's going to need surgery. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to do what? Up to 45%. What do you do? So up to 45, it's wear a brace 23 hours a day, take it off for showering only, then put a cotton t-shirt underneath, to help the rubbing. Of course, always inject the area, no lotions, no powders. And with that exercise, you can strengthen the core strength, and these children do much better. Their spines do straighten up. A multi teaching for a child with scoliosis with less than 40 degrees of curvature. So what are you going to teach? So 23 hours a day, cotton shirt underneath, no lotion, no powder, and then physical therapy to help strengthen their muscles. A multi, a Pavlik harness. So Pavlik harnesses are used for children with developmental dysplasia of the hip. It holds the hip in abduction like Bogart, B for Bogart. And then you have to check underneath that brace for any skin irritation because they move and it does rub, okay? And they're saying that you should, rub that area underneath just to make sure it keeps nice and full of circulation and no breakdowns occur. What is osteomyelitis? And that's basically an infection of the bone. And you mostly see this, it's going to be the outward appearance. It's going to be that redness, swelling, pain. Of course, it's going to go septic and infection with elevated white blood cells and whatnot. Osteomyelitis, it's very difficult to treat. So, again, trying to get these parents in before it gets to that point. Joel's goals of juvenile idiopathic arthritis includes what? And you could look at this and say, any child with any condition, what all do you want from them? You want to reduce their joint pain and swelling. That is our absolute goals. That's number one. And when we do that, they can be more independent. They can have, less stress on them. And then, they can be more mobile and active, which is what we want. We want kids to be kids. A multi. What might you anticipate for a child diagnosed with JIA? Facial rash happens to be lupus. It is not JIA, but joint difficulty walking. And don't forget that uveitis, the eyes. It's cerebral palsy. So cerebral palsy is all about the person's inability to move their body the way that they want and to be coordinated. The brain just can't work on those nerves and muscles. It just doesn't work. A multi. What are the signs and symptoms of spastic cerebral palsy? Absolutely classic signs. I remember spastic cerebral palsy is their most severe of all, that you would see these symptoms a lot stronger than some mild ones. Poor posture, poor fine motor skills, hypertonicity, poor balance. They do need a lot of support. A multi. When feeding a child with cerebral palsy, what's important to remember? So again, cerebral palsy is a problem with the muscles and working their muscles. When you eat, you're using muscles, your jaw, your mouth, your tongue, your swallowing, right? So think of it that way. What do you need to hear? Elevate the head of the bed, and then you give that child time to swallow. And believe it or not, thick liquids are better than thin. Thin they choke on. Thicker, we do a lot of thickening liquids on these type children. Myelomeningocele. So a myelomeningocele is the spinal cord and meninges. They're sort of from the bottom ripped up and they're pulled to the out. And they've got this big sac there. And it's that hernia. Again, your goal in this, just like the omphalocele, right? Or the bladder exstrophy, keep it clean. That means put normal saline, sterile dressings, maintain skin integrity, and keep the infection away. What can help a child with lupus prevent exasperations? It's the one thing I told you about lupus. So lupus, one of the big ways that they can get, these flares is actually sun. So wearing sunscreen and decreasing that exposure to sunlight. Also, just like any immunosuppressive disease, any of them, like lupus, like JIA, prophylactic antibiotic steroids before we do procedures like dental extractions. Infants with a myelomeningocele demonstrate what? What would you expect to see? Those nerves have been pulled from the bottom with the spinal cord, the meninges, and are on the outside. That means there's some tearing of those lower extremity nerves. And when you see that tearing, it's going to be motor and sensory impairments, okay? Both of them. And remember, with myelomeningocele, with motor and sensory impairments, we need to be concerned about urine and bladder control. We need to monitor it closely. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor what closely? We're all about that urinary retention. Now, yes, with decreased motor sensations, we'll be looking things like foot drop, skin breakdown, contractions. Yeah, that's an ongoing everyday thing. But the one thing that we really need to look really close is bowels, if they've moved them, and urine. Are they urinating or do they need to be catheterized? Many of these children end up every 4 hours being catheterized. A key feature of Duchenne muscular dystrophy. It's a progressive muscle wastage. Muscles are the diaphragm and the heart, and those muscles usually fail when they're teenagers. What is one of the procedures that a child with possible Duchenne's may need to diagnose the condition? So you have a child, male, ages 3 to 7, who now has hypertrophic calves and are starting to fall down. Well, we see in muscles there's a problem. So the test we do is about the muscles, electromyography or EMG. Remember, you have spasmed every muscle in their body, and possibly they feel like they've gone through a marathon. So just like you, who've gone back to the gym after 2 years not being there, you're going to hurt when you come home and the next day. So maybe some acetaminophen or some ibuprofen to help that child. Who is Duchenne muscular dystrophy inherited? And it's mommy, X-linked recessive. In caring for a patient with Guillain-Barré, the priority concern is what? And it's all about because all of a sudden the nerves hit the phrenic nerve and it deadens it. And now we can't have a nerve to tell the diaphragm to go ahead and breathe. So it's all about airway. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? So remember, it starts from the feet and it works up. That's called ascending. Okay. Die. Treatment for Guillain-Barré include what? So antibiotics, it's a virus. It's not going to do anything. So no antibiotics. Um, IVIG, we want intravenous immunoglobulins. Let's boost that immune system. And of course, we're going to need a ventilator, respiratory support. Now, heparin might be used as a prevent blood clots thing, but it's not the treatment for Guillain-Barré. So the treatment, IVIG and a ventilator. What type of cerebral palsy causes hypertonicity and poor fine motor skills? And this is what I told you to remember. Usually when we talk about these things, it is spastic. Good. What priority action should a nurse take to a patient with a suspected spinal cord injury? And very good. Thank you. Yes, take care of that spine. Good job. You should get a tetanus shot every what years? Do you know it used to be when I first started every year, then it was every 2 years, and then it was every 5 years. But today It's not just a tetanus shot. It's tetanus and diphtheria, and it's every 10 years. It's a symptom of tetanus. Remember, that's lockjaw. And remember, tetanus is from some dirty something got into the body and it's creating symptoms and squeezing the airway shut. And it's called lockjaw. The spasming of muscles is so severe and it occludes the airways, so they need to be intubated. And of course, really strong muscle relaxants relax that body because it's that painful. And last question. Most common causes of spinal cord injuries are and it's any sort of accidents. It could be sports, motor vehicle, driving something, just gotta always be careful, right? We wish. Number 3, Moni. Good job, Moni. Number 2, Dan the man. Good job. And number 1, Tammy. Good job, Tammy. And Albert. So this is the end of your class for today. Of course, you're going to get it posted. Remember to, if you want, come to the review tomorrow. If not, of course, I'll be sending it to you as soon as I can. Please keep a lookout for your projects, right? Those projects, you can get one chance to redo it. And not only do it, send me a message. Hey, I've redone it. Please, could you go back and check my project? Okay. Any questions? Thank you, guys. Have a good night. Kisses to my little boy, Ariana.